I feel like that's my favorite.
Okay, ready? Okay, good morning. I'd like to call the meeting to order and ask the secretary to call the roll, please.
Director Garza?
Present.
Director Kim? Present. Director Sorrell? Is absent. Director Webster-Cross? And Chair Bott is absent, but will be here in a few minutes.
Okay.
You do have a quorum.
Thank you. And do we have anybody participating remotely?
We do not.
Okay. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Friday, May 16th at 9 a.m. Is anyone registered to provide in-person or virtual oral testimony or submitted written testimony to be included into the record?
We did not receive any registrations nor any written testimony.
Okay. Let's go to item 3A, approve appointments, reappointments of Stroger Hospital Department and Division Chairs. Presented by Dr. Kumapli, Interim Chief Medical Officer, and I apologize if I butchered that.
Thank you. Good morning, Chair Garza and Directors. I'm respectfully requesting approval for the appointment of 5 individuals as division chairs of the medical staff of Stroger Hospital for a 2-year term running from the 1st of April 2025 through the 30th of April 2027. 3 of the requests are for existing chairs and 2 for new chairs. The first request is for Dr. George Paul, who has been the chair of the Division of Pediatric Emergency Medicine since 2018. And he has been with Cook County for about 20 or so years. The second request is for Dr. Alexander Soper, who is the chair of the Division of Surgical Critical Care since 2018. He's been with Cook County since 2011. And I would say when the story of robotic surgery is being told about Cook County, that story cannot be told without Dr. Soper. He has been strongly behind this effort, and I'm glad we were able to see it through. The third request is for Dr. Feto Gloss, Division Chair of Cardiothoracic Anesthesia since 2010. He's been with Cook County. He came in as an intern in '99 and joined as an attending in 2003. The first new request is for Dr. Vesna Petronik Rozek, who was named the chair of the Division of Dermatology last month. She graduated from the University of Belgrade in '89 and did her dermatology residency in Thomas Jefferson University in Philadelphia in 2003, and then also did dermatopathology, University of Chicago in 2004. She joined Cook County Health 4.5 years ago. She's currently serving as both the division chair and the interim program director for our dermatology residency program. The last is also a new position, Dr. Tariq Al-Yusuf. He is the chairman of the Division of Cardiology. He graduated from the University of Damascus in 2002. Actually did his residency and chief residency with us in Cook County. Finished that in 2010, did his cardiology fellowship and chief cardiology fellow here in 2013, and then did interventional cardiology in the University of Nebraska, graduated in 2014. He had left our institution for a few years and came back in 2017. He was proud to this position, the director of our coronary critical care unit. Dr. Al-Yusuf is a phenomenal clinician educator, having won 10 teaching awards, including 2 prestigious Osler Awards. And what's remarkable is he had left Cook County for 4 years. And so between 2010 2007 and 2013, he won 5 teaching awards, and between 2017 to 2020 and 2023, he also won another 5 awards. Dr. Yusuf will be partnering Dr. Duki, who is the medical director of the cardiovascular service line unit. Dr. Duki was the previous division chair of cardiology. That's the end of my presentation.
Thank you. I'd like to entertain a motion to approve item 3A, the 3 Stroger Hospital Division Chair reappointments and the 2 Stroger Hospital Division Chair initial appointments. Is there a second? The motion has been made and seconded. Is there any further discussion on the motion? Okay, if no further discussion, and I'm hearing none, then all in favor, please say aye. Aye. All opposed? Okay, the ayes have it. The motion carries. Thank you. I will go to item 3B, EMS, MEC reports, action items, Stroger Hospital and Provident Hospital, med staff action items presented for approval. So I guess I'm presenting those. Is that right, Debbie?
It is Dr. Patrinakos and Dr. Allegretti.
Okay, thank you for that. Yes, we'll ask Dr. Patrinakos to come up and present any reports, and we'll present the medical staff action items for the committee's consideration and approval.
Okay, good morning. So we'll start out with the summary of the HQs. The first one being nursing. In terms of hospital-acquired pressure injuries prevention, we met our benchmark in 2024 with a less than 10th percentile in ND and QI data. In 2025, our goal will be a 25% reduction in preventable HAPI cases. In terms of pain compliance, work group initiative, the target was 95% documentation, compliance for pain assessment and intervention. We're going to be piloting a network flow for high risk units. Barcode medication administration compliance, the goal was to maintain a greater than 95% compliance. We had some issues in terms of scanner availability and gaps in OB and PEDS units. The plan is to address ID support concerns and improve bedside scanning workflow. We can move on to hemodialysis and peritoneal dialysis. Dialysis adequacy targets, peritoneal dialysis adequacy. The goal was 96% of patients to achieve a KTV of greater than 1.7. Our current compliance is 93%. Anemia management, we have some barriers in terms of insurance delays and ESA authorizations. The plan is to implement prior authorization tracking systems. Action items and also include increased real-time monitoring for ESA medication adherence. There were no actions for EMS committee, and there are no recommended actions for the QPS committee. Any questions?
Okay, no questions. Thank you. We'll now hear from Dr. Paul Allegretti, please, President of the Provident Hospital Medical Executive Committee, and he'll present any reports on medical staff action items for the committee's consideration and approval.
And Dr. Allegretti is remote.
Okay, thank you.
Good morning, everybody. Sorry I couldn't be there in person. With the change in the meeting date, it ended up being on a day I'm working clinical at Provident. So I am going to just present the members for appointment and reappointment for the medical staff of Provident. The committee held a meeting on March 25th and approved those members that were attached. And this was also approved at the Med Exec meeting on April 4th at Provident. And I'm here to respectfully ask your approval, and if you have any questions or comments, I'm available.
Okay, I'd like to entertain a motion to approve item 3B, the Stroger Hospital and Provident Hospital medical staff appointments, reappointments, and changes. Thank you. Is there a second? Thank you. The motion has been made and seconded. Is there any further discussion on the motion? Hearing none, then all in favor? All opposed? And I'm an aye for approving. All opposed? Hearing none. The ayes have it. The motion carries. I'll turn it over to the real chair of this committee.
Thank you, Director Garza.
Well,
Apologies, being late. Good morning. We'll go on to our minutes. The March 14th, 2025 minutes were approved at the April 4th board meeting, so they're being presented for the committee's review and discussion if necessary. Chair inquires, are there any corrections that need to be made to the minutes? I'd like to entertain a motion to accept item 3C, the minutes of the QPS committee meeting on March 14th.
I'll make the motion.
Any motion been made and seconded? Is there any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it, the motion carries, and thanks to Dr. Patrinakos, Dr. Allegretti for their reports, and welcome Dr. Patrinakos to this meeting. Thank you. We'll go to operational excellence as well. Next, the 2025 IFX dashboard goals and tactics. So, Raji.
Good morning.
Good morning.
Morning.
Good morning. Okay.
All right.
Okay. Before us, we have the Stroger OpEx Committee dashboard. We are pleased to represent for Stroger that on the dashboard, one of our measures is meeting our stretch goal, which is our COPD work. 3 measures are meeting the target under nurse communication, our ED length of stay, and our post-hospital appointment days. 3 are better than baseline, which is our provider communication top box, our work in the PSI 90, and our geometric length of stay. And then we have 2 opportunities for improvement in our sepsis bundle and our mortality. If we go to the next slide, please. Next slide. Next slide. Okay. Thank you so much. Okay, as we look at deep dive into each of our metrics, under our patient experience for provider communications, we have met our quarterly expected increase in our physician communication domain by more than double the improvement. We're also 2.9% higher in 2025 compared to our work in 2024. Our March rolling 12 months is at 84.80 top box, and our March top box is sitting at 82.05. Next, looking at our nursing communication, we've met our quarterly expected increase in nursing communication by more than double the improvement. We're also 6.2% higher in 2025 as compared to 2024. Our March rolling 12 month is sitting at 73.55 for the top box, and our monthly top box for March is at 75.25, above our stretch goal. Moving down into our mortality. So far, we have not met our quarterly expected decrease in our mortality. We do have 1 more month left in the quarterly goal, and we have seen a reduction in 2025 compared to 2024 by 7.9%. February 12 month is at 1.0, and February monthly is at 0.86, which is lower than our month prior. For our patient safety indicator, so far we have met our quarterly expected increase in PSI 90 composite. We still also have 1 more month left in the quarterly goal. But we have seen a reduction in 2025 compared to our 2024 by 20%. February, we're sitting at 0.97, better than our baseline, and the February monthly is at 0.81, which is lower than the month prior, and also at target. For the work in the sepsis SEP 1 bundle compliance, so far we have not met our quarterly expected decrease in our sepsis bundle. We still have 2 months left in the quarterly goal, and this measure has not improved when compared to year over year. But we are currently undergoing our CMS audit for this measure. January, the 12-month is sitting at 47.03, and January monthly is at 44%.
All right, we're going to stop and see if there are any questions or comments on this. Good work on the patient experience part. We can maybe follow up the other clinical outcomes in another meeting to talk about opportunities there.
Okay, thank you. Rolling down into our readmission work, and thank you for that comment on our patient experience. We are very excited about the work that has been done and our results. Moving into our readmissions, first on the COPD rate. Currently, we're meeting the stretch goal for the rolling 12 months. We have been meeting our stretch goal for COPD patient readmissions, including age and payers, and we look at our payers and age due to our volume being too small to look at Medicare only. For the post-hospital follow-up, so far we've met our quarterly expected decrease in post-hospital appointment times. Our 2025 year-to-date compared to 24, we've seen a 38% reduction, and this measure is starting to show some improvement trends. Our rolling 12-month is at 23.1 days at target, and March came in at 15.60, which is lower than our month prior.
Oh, before you go further, there's Pat Merriweather's remotely connected and has a question. So Pat, what do you want to ask? Sorry, I missed you.
I just wanted to congratulate you on the patient experience. That is so critical, and what a great achievement. So congratulations to all. On the sepsis bundle, again, there's been a lot of discussion because the Sepsis Alliance had the annual meeting last week, and there has been a great deal of discussion on sepsis, and sepsis that is presented at, in the emergency room, or no one has a good handle yet on how long that patient had not been seen, in terms of waiting to get to the emergency room. So again, I think this is a hard one because it still requires a lot of public education and education upon discharge. But again, I think that's where some of the challenges are still.
Thank you, Pat.
Thank you.
All right.
Thank you so much, Director, for those comments. Moving to, lastly, in our work in throughput. So far, for the GMLOS, so far we have met our quarterly expected decrease in our GMLOS data. The 2025 year-to-date compared to the 2024 by 14% reduction. This measure is starting to show improvements. In February, our number is sitting at 1.72 days, average above the expected geometric mean, which is better than our baseline. And February is at 1.54, which is lower than the month prior and also better than the baseline. And lastly, for the ED length of stay for ED discharge patients, so far we have met our quarterly expected decrease in our ED length of stay for treat and release of ED patients. Our 2025 year-to-date compared to 24, we've seen a 1.3% reduction, We still have one more month left to report and to close out the quarterly performance. Our February 12 month is at 305 minutes, which is at target, and our February month is at 380, which is a little bit of a recent spike, but maybe an anomaly. We're looking at that and certainly continuing to watch that as we move forward.
Thank you. Any questions, comments?
Can I?
Congrats on the progress in these areas. Good to see.
Dr. Butt, just reiterating your earlier point about patient experience work, that's really amazing. The first metric out there that had, the physician communication metric that had been historically our top performing metric. But last year, once we started focusing more on the nursing communication domain, we saw a little bit of dip in our performance, as you can see there. But then we brought that metric back in our focus, and since then it's been performing really well. It's actually one of the top performing metrics nationally, so we're very happy about that. And kudos to Danica and the nursing leadership on the Georgia side for bringing up the nursing communication domain. That has been a metric that needed a lot of TLC on our end, and it's starting to turn around. So congratulations, Danica, Dr. Peters, Dr. Witten, and the Georgia team working actively on that. And Ling has more to talk about other specific tactics and measures it took the team to turn those numbers around. The other one I want to call out is the clinical outcomes related to the mortality index. I know it looks red all across.
Getting better.
Yeah, and also we have revamped that process. Congratulations to Dr. Kumabli and his team. There is a new CDI process where they are doing close to real-time monitoring of all of our mortality cases. So, so even though the numbers spike, it's because we have better handle on the metric. We are very confident that number will be coming down soon. Ms. Meriwether, I appreciate your comment on success. Yes, it continues to be our focus. Just so you know, it's not the quality of the work that has gotten worse. It's just that we introduced an external vendor in abstracting data for us, which allowed us to make sure that our data mining and abstraction is up to the standards, at the national level. This external group, who has hundreds of other members in their, in their customer base, uses a very strict, parameters for monitoring success work here. So that's where you see a sudden dip, around mid-year last year. Yeah, and I can promise you that it's not the quality of our care, it's how we are defining, the sub-one bundle compliance that has made the difference. But again, we have the CDI team and the quality team doing close to real-time monitoring of all these cases. And thanks to Dr. Peters, we are able to hire a substance coordinator who is going to help us with real-time monitoring of patients who are identified, in ED and in our ICU. So that will remain as a major focus for us this year.
Thank you for the additional information, Raji. Congratulations to the team. Give our best to them for their hard work, and then appreciate the additional information on clinical outcomes. The sepsis piece we've got to still work through, so let us know, how we can help the team with that. But appreciate the continued work and the additional efforts on that area.
Thank you. Thank you.
Directors, other reactions, comments? Okay.
Yes, I just want to say, I think you're doing great work, and my suspicion is that many patients sit at home thinking that this is just a normal course that they're going through with their condition. And we find that many times patients have never heard of sepsis, and they wait to get care, and sometimes it is too late. because again, the delay that they have, not in accessing healthcare, not in the emergency room, it's the time that's spent at home that, again, they just don't realize what sepsis is.
Thank you.
That's an absolutely important point. We have to extend the work that we are doing on the inpatient side into the community setting. So we are working closely with ACH and team right now. And once we have, formalized our pop health initiative, we would definitely be working closely with them as well.
Yep. Thanks for bringing education into it. It's both the patients and their families and the clinicians as well. And appreciate the call out to Dr. Kamalpale for your work. Thank you. All right, Providence. Dr. Turner, good morning.
Good morning. Dr. Arnold Turner, Chief Hospital Executive, Providence Hospital, Cook County. Before you have the dashboards of our metrics for OPEX committee dashboard, we have one metric that is at goal, 3 that are better than previous baseline of 2024, and 2 that are still have not made any changes toward improving from the baseline. Next slide, please. Looking at the patient experience, we have not met Q1 goal of increasing the survey return rate by approximately 3 surveys. We are down by approximately 7 from our goal. We came in at a return of 15 surveys, but expected 21. This is a very vital metric because it impacts the information that we get from our patients about how our service really is, and we definitely want to improve that. Next, looking at nursing communication, we are just shy of meeting our quarterly improvement rate of 0.613%, top box for Q1 of 2025. We have improved, but not quite at the benchmark expected for Q1. Likely this is due to a lower survey return rate, therefore making interpretation of our scores very variable and not statistically significant. March rolling 12-month rate is at 73% top box. The goal is 80. March monthly top box for March is at 60.32%. We're looking at our tactics for that, and hopefully soon we'll see improvement, continue improvement toward the quarterly goal. Moving on to sepsis. Our sepsis rolling 12-month rate is still trending better than baseline. So far through February 2025, we have not met our quarterly expected improvement though. We are shy by 7%. We still have 1 month left for review and compliance to see where we land. February rolling 12-month performance was at 58.62%. The target is 60%. February monthly performance was 0% due to lack of documented blood cultures collected, dates and times, repeat lactate missing from the bundle compliance. The previous 3 months, though, we were either at target or above target. So we're going to have to take a look at what happened in February. Falls, we continue to do well. Falls 12-month is at target. We have seen 3 falls year to date for the year 2025 have met the quarterly goal reduction for Q1 2025. March rolling 12-month rate had 16 falls in the last 12 months. For March, currently we had 1 fall. With respect to left without the NC, we continue to do well. We meet the quarterly expected improvement, about 4 times the reduction expected. We have seen a 74% change in left without the NC rate compared to 2024. March rolling 12-month rate came in at 2.78%. The goal is 2%, while the March monthly came in at 1%, and the stretch goal is 1%. The last measure we're looking at with respect to throughput is the ED decision to admit to departure of the ED. has met the quarterly reduction by 4 times the expected time reduction. We've reduced the time frame by 15% compared to 2024. The March ruling 12-month comes in at 124 minutes, just shy of the 120-minute goal. The monthly March comes in at 107 minutes, meeting the target. Okay. Any questions?
Just a quick question. Georgia made a great progress on physician communication, but I don't see that item on this. I'm assuming you have different set of goals, but am I understanding right? Like Providence already achieved some level of communication?
That metric is monitored for Provident as well. However, the task of the OPEX work group was to identify 2 or 3 goals that they thought would be the most, important ones for where they were performing. They could improve, better on. So Lynn is going to present on patient experience data now, and she will touch on that. So that is still on a, it's something that we do track internally, but that's not what the Provident OPEX team is actively working on.
Great, thank you.
Regarding the sepsis for the monthly, the 0%, because there was, I'm just curious about how many patients was that when something was made.
Director, Dr. Cross, I don't have the volume per se, but I'm happy to get that information and share that with you. However, that remains the major challenge for us. Since the volume is really low, even with, that all the teaching that we are doing, all the process improvements that we are putting in place, that's the challenge with maintaining sustainability over time. For example, Dr. Turner's ED team has launched a beautiful project on blood culture, maintaining the blood culture cleanliness. How do we collect? How do we reduce the contamination of the blood culture collection? Sorry, I couldn't get that down. However, even though there is a lot of work happening with all the turnover and the fact that they use a lot of agency staff at Provident, it has been hard for them to maintain, the consistency in their practices. But, with the sub-1 bundle, if we fail to collect, we meet the goal for one of those bundle elements, then, we get dinged really bad. So as Dr. Turner mentioned, this was the blood culture collection issue that we had. We weren't able to collect it in a timely manner. But the team is actively working on, and they have many sub-projects that would support this goal, like the blood culture collection and, lactate collection, the Cerner alerting, so, we don't depend on human memory to collect them in a timely manner. Very good. We are hoping that, the team would be publishing their throughput data related to left without being seen at some of the national platforms this year, because it's pretty impressive how they brought down the numbers from 12% to almost under 1% in a year or so. So that's something to highlight.
Great. Thank you. Thank you. Go to, talk about ACHN site review, Craig. No. It's online, remote. It's not the Raji, you
I
wanna,
will present.
yeah, you wanna
Okay,
just go through it?
Yes, thank you. So their first OPEX work group, its first set of OPEX work group metrics related to patient experience have been trending really high for the past few months. Increasing the rolling 12-month staff work together for you is a new metric they started tracking this year. So as you can see, last year the performance, rolling 12-month performance has not been up to the par. But the team has put together a group that would be focusing on specific metrics related to that. And, the monthly numbers have been starting to look good. We are very confident that, the numbers will turn around pretty quickly. Related to care provider addressing concerns and worries, for the past 6 months, they've been performing above their goals or their target stretch goals. They have been performing above their baseline and their target. So that number, that metric is really looking good. For the care provider explaining problems and conditions, the team has been showing some amazing results for the past 6-7 months, even to the point that their stretch goal has been met for the past month. Moving on to the HEDIS measures, the breast cancer screening rate, as you can see, for the past 3 months this quarter, they've been performing above their stretch goal. And for hypertension management, the team has really set their goals a little high for 2025 because their performance in 2024 was really amazing. So as you can see, even though you see the red metric for March, I just want to reassure the board that that's because they set their target really high for this year. The team is continuously, actively working on that. That's a metric that ACH and team is very serious about and will continue to focus on. Related to empanelment, as you can see, since they identified this as an OPEX goal for 2025, they've been performing above the baseline. So that work needs to continue. It's a new goal for ACH in this year.
Hey, thank you. There's a lot of good progress here. Any thoughts about the breast cancer screening rate in terms of how the work that's being done to address or improve that?
Yes. Craig, if Craig were here, he would have definitely talked about how we introduced the birth date screening program for both breast cancer and prostate cancer screening. That has definitely helped them with getting those numbers up. So, several metrics, several measures and tactics they implemented. However, that birth date screening has been the most effective.
Any other questions, Director? Thank you.
If I may, if I could brag about a few different things
Yeah.
that we are doing.
Well, I want to celebrate the team.
Let's celebrate the team. We have been able to secure a scholarship from the Joint Commission, which would allow us to develop a cohort of 8 quality leaders here. The scholarship will cover the cost of, getting our leaders trained to be certified as a professional in healthcare quality, CCH through NAHQ. So that was something we are very happy about, very proud of. The other thing is we will be working with, when I say we, Ling, Dr. Mikaitis, and I will be working closely with Dr. Tam Lee, CMO of Proscani, to publish a case study on employee engagement. And Dr. Mikaitis will also be working with Dr. Tam Lee to do a podcast in a New England Journal of Medicine. Woohoo!
Terrific. That should be.
And I will be presenting at Becker's in a couple of weeks on a quality-related topic as well. So, thanks, Steve. Oh, the podcast actually will be on board engagement in improving safety and quality. So it's actually to Europe. So thank you.
Congratulations.
Congratulations. Was glad to see that Dr. Lee's engaged with us so very much before. He's got deep experience and perspective, so helpful to have his contributions. Great, it was great work. And one question about the quality leaders, are they also going to be involved in any of the areas where we're continuing to try to make improvements? Or do they have to do a practicum, or is it just the certification training?
Yeah, we are still figuring out, but we were told that the criteria of selecting who those 8 leaders would be up to us, but Dr. Dr. Mikaitis and I have talked about making it a system improvement. So we would have some nursing leaders who are leading some of this work, physician leaders, as well as folks on quality, but we will make sure we do extend this opportunity to all our sites for the rest of our and
Great. Wonderful, thank you. All right, appreciate the report, and we'll go to our regulatory and accreditation update. Joseph, minutes.
Morning.
Good morning.
Yeah. I'd like to provide you a brief update of regulatory and accreditation. We'll start with Joint Commission survey of Providence. We had an assessment visit that took place back on March 4th. We did successfully submit a 10-day clarification. It was approved by the Joint Commission. We're currently working on a single corrective action and working through the process right now with the draft of that. Joint Commission updates, I do have one for Providence as far as the application. This is for the Bronzeville Clinic for Behavioral Health. I'm updating the application. It's 30 days, so that will be submitted before week's end after a final review. Also, an IDPH complaint validation visit on patients' rights that took place. Looks like at Stroger on March 31st and April 1st for 2 days, 2 surveyors. We expect the report any time now. It's just been almost 2 weeks now, so I've been looking for that report. It'll be coming to my direction, so again, looking to wait for that come in, and there's a quick turnaround with that type of report through IDPH. Imminent surveys. IDPH outpatient dialysis, again, it's expected at any time. We've been waiting for this for a few months now. We hope that this will come soon. We've been preparing for it for quite some time. I do have one to check off the list. Joint Commission primary stroke is every 2 years. We had the confirmed visit of April 1st through 2nd. One survey for 2 days. The survey was very complimentary on the program. We had one evidence of standards compliance or finding, and we have the final report, and we're currently working on that draft.
Congratulations.
Upcoming surveys. So Joint Commission Healthcare Equity. We have, this is in process. It's going to be a first-time certification for us. We have a document upload, which is basically an upload to the Joint Commission portal that opened on Friday. We are going to be actually working on this upload today, just a couple hours. And what this is a document upload that's in advance of the surveyors coming in so they can review and be prepared before the site visit. We have preparation underway. We have a planned ready date, June 10th. And since this is a first-time certification, we will get a 30-day notice. That's nice. We expect one surveyor for 1 day. I did want to provide an update to the board as far as a question I think was asked in February as far as changing in administration, if there be any type of changes. Initially, when I called in, I was told that they weren't aware of any at that time, but timing is everything. I just got a phone call last week from the Joint Commission, and they mentioned that 3 standards are going to become optional because of the changes in, I guess, federal changes in government requirements. That will fall under data collection, provision of care, performance improvement. So what does that mean? It means that there will still be standards that are within the intent, so to speak, but they will no longer be scored. So if they come in and they find that we need best practices, some challenging areas, they can give us advice, but we would not get a deficiency on anything. We have been working on these for quite some time. We plan to move forward with working on these as well for the site visit, but I want to make people aware of that. So there has been some changes that I just, like I said, alerted to last week. As far as upcoming surveys, continuation, American Colleges Surgery, Bariatric Accreditation, we have a planned survey date of Friday, July 11th, 1 day. We have American College of Surgeons Trauma Center. We have a survey date of August 12th and 13th, Tuesday and Wednesday. This will be a virtual site visit, so a little bit more challenging when it comes to documentation being prepared in advance. We're working on that. And lastly, IDPH EMS Resource Hospital Site Survey. We're expecting to be ready sometime in the fall of 2025 or early spring of 2026. And that's what I currently have for updates. Answer any questions?
Thank you. Director Garza.
Yeah, I just want to go back to the three standards. I think you're saying it, but just to make sure I understand, these are related to DEI, right?
Yes.
DEI data collection for staffing and not patients.
This is the data collection. I don't have the elements in front of me, but I can absolutely get that for you. Provision of care,
Yeah.
and performance improvement, and they include elements of performance, which is basically a substandard. There's a couple that fall under that standard. And again, it become optional. So what that means is, if we're collecting on it, we want to share it, which we are collecting on, we can then, they will give us feedback, but, if we fell a little short, they will not score them in the actual final report.
Dr. McIntyre, we'll add maybe some more.
Yeah, so it's a little bit of both. Director Garza, there's some patient-facing health equity focused things that have gone to the optional, but then also some staffing components. We're taking the tack of if we have it and we're able to track it, we're still going to submit it. So.
Yeah, I only asked because I spoke with them last week and I wanted to know what they were doing about standards that conflict with the federal direction or federal guidance, so that my own organization wasn't out of compliance with those requirements. And they said that it was specific to data collection for staff, not necessarily patients. Okay, thank you.
But did you just say even if you don't meet the criteria, it's not gonna affect anything? Like, what's the goal of doing that then?
I'm sorry, say again?
Did you say if you didn't meet the criteria, certificate, survey criteria?
Yeah.
What
So,
actually happened after that?
so let's say that we were short on a standard, it was one of these optional ones now. They can give us best practices and tell us how we can then raise the level of meeting the intent, but, if we are short, we are not scored on them. So, you know, kudos to us if we were already collecting the data, already have the information, meet the intent. If we weren't and we decided to drop off, then again, since they're not scoring them at this time, they're kind of, I guess, frozen, so to speak. They're optional. Does that make sense?
So we have the option of not submitting at all. We can just,
Yes.
yeah.
I have a quick question about IDPH, complaint validation visit. What is that?
This was the patient rights visit that happened over 2 days, the end of March, beginning of April, the 31st and the 1st. We're expecting a report anytime now. Just hasn't come in yet, but it's going to be directed towards me because I gave them my email address. It could happen as early as today. I expected maybe the end of last week, but I expect hopefully it'll be in before the end of this week. And then they give us typically 10 business days to turn that around as far
I
as
guess my question is, what is that about?
Okay,
Sorry,
Director Kim, would it be possible for us to give you the details of, we don't know, the IDPH never tells you exactly what the complaint, that they received. Oftentimes, we kind of discern from the, you know, the type of survey they do, type of document they look at. So we don't know exactly what the complaint was, but, if we could connect with you outside of this
Yeah, I was just
meeting,
gonna say,
we
can
would
we,
be, yeah,
Got
yeah,
it. Thank
can
you.
we just have a follow-up?
will do.
All right, thank you.
Thank you.
We have a report from our Chief Patient Experience Officer. Lynn?
Good morning. Very excited to share with you some of the great things that we're doing at Georgia, and due to time, I'll try to get through my slides within 10 minutes. We have some time for Q&A. So the first slide, this is the report of all the cases during fiscal year Q1. As you notice, January has a higher number of complaints and grievances. After looking more closely to the data, it turns out that we had about 16 more parking ticket issues than we normally would. Normally, we would get about 20, 22, but that particular month we had more. So we didn't really have a grievance or a complaint, but just more parking issues, and that was tallied into that number of 181. Just to explain to you, when we have the parking issue, it's because a patient lost their ticket, and instead of wanting to pay $30 the ticket, they come to patient relations to get a flat fee of $5. But, and also just to give you a heads up that in March, our numbers went down to 115. So we are working on diminishing the complaints and grievances. And the progress could be a direct link to our teams focusing on real-time service recovery. And also thank you to Dr. Peters. She actually hired more nurse managers, charge nurses to do hourly rounds, and also increase the night shift and the evening shift. Next slide, please. Okay. So here we have the reports broken down by facilities and by month starting December. Since in last December, we reported from January to November. Given the scales and the volume of operations at Stroger, it's expected that the majority of the cases originate from Stroger, as it serves the highest patient throughout our network. So next slide, please. Here is another perspective of the data. I want to take a moment to remind you the difference between a complaint and a grievance. A complaint is when an individual has an issue and we would resolve it the same day, right there and then. A grievance is when they had a bad experience or something happened, but they didn't bring it up to us, and they went home, they thought about it, they either write a message or call us or post it on social media. That's considered a grievance when we did not close their issue on the same day while they're on campus. Okay, and then also the grievances that CMS looks more closely at and has requirements. I will share more on slide 7. So here are the top 10 most frequently reported issues, and as you can see, parking is one of them. So we rolled out our CI Care. We have seen a decrease from previous report for behavior and respect. Honestly, before we used to have about 189 for behavior and respect, and this quarter it actually diminished to 77. So kudos to the staff members for showing the patients with courtesy and respect. Next slide, please.
What are some examples of accommodations and access?
Accommodations and access when they are trying to get appointments and they're not, it's taking them a lot longer than they would like. So to them, you know, if they want an appointment today, they want us to accommodate them and have and give them that appointment today, which is sometimes really hard. Yeah.
Thank you.
Okay, next slide. Okay. Here's the breakdown of the top 5 categories for grievances, not necessarily complaint and grievances, just for grievances. So behavior and respect have emerged as the most reported grievance category, you know, highlighting an important opportunity for continued growth. Just on highlight, behavior reports respect dropped from previous report of 99, and now we're at 51. We know this underscores the need to strengthen our culture of empathy and patient-centered care. We are actively addressing this through CI Care training, which emphasizes on communication, conflict resolution, and respect. Next slide. Okay, this analysis is based solely on grievances. There's a total of 105, and here it's the time of resolution for the grievances. And as you can see, the majority of the cases are closed within 30 days. And we send out acknowledgement letters sent by within 7 days. And CMS requires that we do this 80% of the time. And we are so good. We're doing an amazing job because we send out the acknowledgement letter 100% of the time. So we're 100% compliant with CMS requirements. And then closing the cases 30 days or less, we're at in December we were at 96%, and in January 92%, and February we were 100%. The 8 cases that were over 30 days, I just want to clarify why we would even have them. It's because sometimes we had to do investigation, or a chair had to interview one of their staff members who were on FMLA or on vacation, or it might involve HR where they have to do investigation, and then compliance has to do the investigation, so that's why it would take longer than 30 days. Usually when that happens, we send out another letter asking or notifying the patients that we need additional time. Okay, so here are the demographics of the patients that are served, that we serve at Cook County. 43% are Black Americans and 36% are white, with the remaining portion representing other ethnicities. The diverse population underscores that we ensure equitable access to care and service that the needs of our community members. Next slide. All right, so now the fun stuff. So here, we've improved in communication with nurse domain. This, the improvement, we have some factors due to additional recruitment of nurse managers on med-surg floors to cover evening and night shift. This means we started hourly roundings during those shifts. And also we've launched the CI Care 2.0 in October 2024, where we focus on compassion. Nurses increase hourly roundings as well, and also they are doing I-rounds on the weekends. Next slide, please. Okay, and then for doctor's domain, we have a new lead for OpEx, doctor's communication, Dr. Phil Alanis, who's in family medicine. He's extremely engaged and has helped move the scores. Patient experience is working closely with Dr. Alanis on the following tactics: creating a LMS module for yearly CI Care training, customized communication approaches based on patients' preferences, and rolling out teach-back methods. And also just to share with you, the doctor's domain, the CI Care is working because treat patient with courtesy and respect is at 88%. And then the other two, where doctor listens carefully to you, is at 81, and then explain the way you understand is at 77. So those are some of the opportunities that we would work on. And we are working closely with Dr. Alanis to come up with some more specific tactics. Next slide, please. So the next 2 slides actually just kind of show you that we are trending upwards. Of course, we still have room for improvement, but this is still a great reason for us to celebrate the good works that our employees and leaders are doing. Next slide. And then the next slide. Okay, so survey response rate. So with the new measure, response rate of patient to our HCAP survey, the questions that they've tweaked actually has helped us improve in our surveys. And so the response rate survey, we recently purchased a multi-mode where we not only have just the mailing, we also have the web mail and the phone calls. And that actually Press Ganey has found that when you do that, it has improved the response rate by 13%. And so we're hoping that that is something that will help us improve in our response rate. Is it 13%? Let me see, sorry. I'm sorry, it's 3%. So 3.14% increase when you do that. Okay, and then next slide. There have been suggestions regarding the provision of incentives. I'm sharing the following guidelines and regulations as set forth by CMS that we must adhere to. We are not allowed to offer incentives, and there could be some ramification if we did. And so this is just the guidelines version 19 just to share with the board. I'm more than happy to hear any other suggestions to help us improve the survey. But again, I'm hoping that the multi-mode will help us increase our surveys as well, and as well as just kind of cleaning out our data. Yes.
No.
Okay.
Thank you for sharing. I know this came up, so any questions or comments from the director?
Okay.
So I think the other thing, particularly with email, is just make sure we have security and support, because it could be something that we don't get impacted by viruses or other cybersecurity issues.
Yeah. Okay. Thank you. I'll look into that. Make sure that we get security to help us with that. Okay. And then can we go to the next slide? Okay. So what's new with patient experience? On the left, you see some of the questions that they have that are new. And able to rest as needed is one of the new questions that's being added. Press Ganey observed that this is the lowest scores across the nation that that other hospitals are getting at 38.8%. However, Cook County is getting 65.72%, so we're doing pretty well. But we are working on continual initiatives to help improve that by using the YACRA tracker, and then also having a mini campaign to help remind the staff that we want to achieve 5 hours or more of uninterrupted sleep for our patients. And then the last questions where the staff work together for you, that's one of the key drivers for us to improve our likelihood to recommend. Now CMS has it said how often team works together rather than just the generic team works together for patients' care. And this actually has helped increase the HCAP scores. Next slide. I have about 2 more slides to go. Here's just to share with you some of the employee engagement events that go on during the year. Next slide. And some fun initiatives that we're doing this year. We have 2 community murals happening, one at the Bronzeville, and this is the artist that we've chosen with examples of her work. Next slide. And then we have Ahmed Lee. He is going to represent the Juvenile Temporary Detention Center. And I don't have the exact unveiling dates yet, but once I do, you will all be invited to that. And that's all I have. Thank you.
That's great. Thank you. And this month, it's Patient Safety and Experience Week, Patient Access Week, and National Public Health Month as well.
Yeah, we had the Patient Safety and Patient Experience Week event last week. It was a huge success. We had Dr. Tom Lee come and present on social capital and the good doctor. And so it was highly successful, and the poster fair was also highly successful. And then through that event, we decided that it'll be like a biannual. We're going to also have an opportunity for our own staff to present the great things that they're doing as well.
Great.
So,
Congratulations.
okay, thank you.
Thanks for the report. Any questions, comments? Okay. So, the committee will now go into closed session. Actions not anticipated be taken in open session after the closed meeting is adjourned. I'd like to entertain a motion to go into closed meeting. Pursuant to the following, exception to the Open Meetings Act 5, ILCS 120/2, 111, 12, and 17. Have a motion again. And seconded. Is there any discussion on the motion? Hearing none, the Madam Secretary, please, take the roll call. Vote on the motion.
Roll call on the motion to go in closed session. Aye or nay? Director Garza?
Aye.
Director Kim? Aye. Director Sorrell is absent. Director Webster Cross? Chair Bott?
Aye.
That's 4 yeas and 1 absent.
Ayes have it, the motion carries. We will now go into closed meeting, so if members of the public and those staff are not required to be in attendance, please exit the room and get started in a minute. Thank you for, your work and report.